This case is an interesting case for CSF disturbance. This is a 50-some-year-old male patient that had a acoustic neuroma in the right side internal auditory canal that has been there for several years. And this is the right upper corner is the 2011's MRI, and in 2012 MRI is getting even larger, protruding into the CAP angle. That result in a surgery. This patient surgery went fine, but the problem is patient developed a headache after the surgery in August 2012. Now it's December 2012. The patient's headache is worse when patients lie down. When the patient's standing up, the headache's better. So we can take a look at the images on the previous study. Patient has a relatively larger left lateral ventricle as compared to the right side. These three pictures are the December 2012 MRI studies. They are in the same study. This is a comparison. Now, patient had a surgery, which happened right here. The bone was removed, and then the internal auditory canal tumor is smaller than before. This is before, this is now. I didn't show you the picture that's really large, that's protruding into the internal cerebellar pointing angle. So it's basically this tumor is smaller because of surgery. But the problem is there is a CSF collection in the subdural space developed. It appeared to have compression, a mass effect compression on the right lateral ventricle. Look at the edge of the cerebellum is straight, and that versus normal on this side. So this CSF collection, signal collection, is probably in the subdural space in the postsurgical bed, probably related to the surgery. It's compressing on the cerebellum, and it even caused bowing of the brainstem. This MRI was obtained in pretty good position. That's pretty straight. So this bowing, like this kind of deviation of the brainstem towards the left side by 8 millimeter is new versus the previous one. The brainstem is pretty straight. Not only that, we can see more finding of CSF flow disturbance. For example, there is a CSF flow jet phenomenon through the foramen of Magendie. This is an axial view. This is a coronal view. This CSF flow usually should be not that fast. Usually we should not see this kind of signal in T1 or T2 images. But we see it now because of the, I guess this we can call the CSF jet phenomenon. Because of CSF flow through their area is too fast. Not only there is CSF flow disturbance, there's also turbulent CSF flow in the fourth ventricle and third ventricle. That's also abnormal for this patient, or for any patient, because usually the flare signal should suppress those signals like this. And also the you can see the jet phenomenon through the left side foramen of Monroe into the left lateral ventricle. You can obviously see this jet phenomenon originate from the foramen of Monroe because the turbulent flow is kind of a circle around this entry point. Same thing here. You can see the jet is pointing towards the foramen of Monroe. So the left lateral ventricle was bigger to start with. Now it's getting even larger. The midline septum is getting more bowed toward the right side. So basically the ventricle size difference is, I guess, is normal variant, but the left side is larger because maybe just like an aneurysm analogy, the bigger part of the cavity tend to be weaker. So if there's any pressure build up from the third ventricle, the weaker part of the ventricle getting dilated even more than the stronger part. So the left side of the lateral ventricle is getting dilated even more with this more preferential CSF flow, backflow into the ventricle. So basically, we don't see any ependymal CSF flow to call that a hydrocephalus, but I think it's a pre-hydrocephalic state. Look at this temporal horn of the left lateral ventricle versus the previous one. I think it's slightly larger. So overall, we have a surgery that result in a subdural CSF collection that compress on the posterior fossa structures and then probably result in CSF outflow obstruction, even though anatomically there's nothing really obstructing it. That's probably result in back pressure and the more turbulent flow into the ventricular system. This is just opposite finding as a lumbar spine CSF leak. When the patient have too much flow out of the ventricular system into the spinal canal and the leak out in the lumbar spine, and those patients have symptom of worsening headache when standing up because of too much CSF flow out of the ventricle. This patient has too much pressure in the CSF. When the patient standing up, the gravity helps the CSF flow out. The symptom is less. But once the patient lie down, this CSF outflow out of the ventricular system is impeded, and the patient felt worsening symptom, just opposite as the CSF leak symptom from the lumbar spine. So I guess the surgeon may have to either drain this fluid to relieve the pressure or drain the lateral ventricles to drain the extra CSF out of the ventricular system. I think this is an interesting case, just a companion for intracranial hypotension. And this patient maybe have some increased CSF pressure, but I do not see intracranial hypertension yet because I do not see any nerve head indentation into the eyeball yet.